in the chat. So this will just be a reminder for you guys. Okay. Oh, sorry, I'm going too fast. Okay, so I don't have any conflict of interest to disclose. Okay, so chest drains and pacing wires are always inserted during surgery as they're finishing up. So this is our usual. We'll put in 2 to 3, or I should say 1 to 3 chest drains to try to catch fluid that builds up in the pleural and mediastinal space. And then the surgeons will place often 2 pacing wires. Sometimes for the less complex repairs, so like a straightforward ASD or VSD, you might just see a ventricular wire. But for the majority of cases, we'll have both an atrial wire and a ventricular wire in case if there's hemodynamic instability post-operatively. It gives us direct access to the heart for pacing. Okay, so I kind of went through indication for chest tubes and pacing wires for cardiac surgery, and I'll fast forward to when it's time to remove them. So for pacing wire removal, we will remove them when we feel certain that our patient won't need pacing, external pacing. It does require a medical order. There should be no arrhythmias before removing them. Sometimes our kids are in a junctional rhythm, and if the rhythm is adequate enough for cardiac output, then we'll make a team decision to remove the wires. Of course, the patient should be stable. Anticoagulation does have to be taken into consideration before pacing wire removal because of risk of bleeding. So if your patient is on a heparin infusion, please remind the medical team that we need to hold that for 2 to 4 hours. I think in the ICU, 2 hours is sufficient. And then if the patient's on the cardiology ward, we like to wait 4 hours. For patients who are on enoxaparin, or low molecular heparin, so it could also be tinzaparin, you just have to remember to do it at the trough. So when the level's the lowest, so before the dose. So if it's enoxaparin, we usually give it at 6 a.m. and 6 p.m. So we'd remove the wires either at 6 a.m. or 6 p.m. before you give the dose. A lot of our patients are started on warfarin for long-term anticoagulation. We do like to take the pacing wires before we start warfarin. And ideally the INR should be less than 1.5. There have been times where, for clinical reasons, our kids are already started and the INR is already kind of on the uptick. It's okay. Like I said, ideally it's 1.5, but the wires have to come out. So in that case, we kind of balance everything. We let the surgeons know what we're doing in case there's a bleed. So it's always nice to prepare the patient and the family for pacing wire removal, give them a little bit of anticipatory guidance of how it will feel. Most patients tell us that it's kind of a cat scratch sensation, but usually we don't have to pre-medicate for pacing wire removal, but it's not wrong to give a Tylenol or Advil beforehand. Okay, so potential complications from pacing wire removal. Number one that we think of is bleeding, which can lead to cardiac tamponade. That's why we really do prefer to take out pacing wires before we take out our chest drains, because if we do elicit a bleed, then at least the drains are in to catch the blood. Of course, when we take out pacing wires, because the pacing wires are stitched right onto the heart, you can create an arrhythmia. And then, of course, wire fragment migration. So I think I get into it a little bit later, but when we're documenting our procedure, you'll document if you saw what you see at the end of your wires, if they're intact, if they're frayed, if you see some tissue. Okay, what you'll need. So I think after this, Carrie's going to do a live stream of an example, but you'll gather your personal protective equipment. So you want to have your gown, your gloves. I guess we are all wearing masks and goggles now, but you would still make sure you have the same for this. You'll need the alcohol swabs, or you can use betadine. Essentially, part of the wire is looped underneath the skin, and so So once you pull back through the skin, we just need to make sure everything we're pulling through the skin is cleaned. You'll need your suture removal kit, gauze, bandage. The patient should be on the cardiac monitor, and you'll need to have your stethoscope. So this is an X-ray example of a postoperative patient. You can see the very thin wires, and they're labeled AVV. So those are your atrial wires and then your ventricular wires. You can see a chest tube in this X-ray, and I think this patient still has their CVL. Those loops going down the center are our sternal wires. Okay, so here's a intracardiac example of what it looks like. So like I said, they do stitch them directly on with a very fine suture, but that's how they remain in place. And then, like I said, our facility, we do this loop under the skin to secure it again on the other side. So here's an example again of what your patient might look like. You can kind of see the loop that I'm talking about. You can see that the little gold ends that attaches to the external pacemaker. So Carrie will go through it, so it'll make more sense, but you can see there's a lot of wire. So we're gonna cut a lot of that because everything on the other side of the loop has to go under the skin. So you wanna minimize as much material going under the skin as we can for patient comfort and for infection perspective. And of course, those golds, those need to be cut off because they won't fit under the skin. Here's a better look at it. Okay, so here's our alcohol swab. We're going to clean around the area. And like I said, you're going to clean any bit of wire that needs to come underneath the skin. And then you're going to cut. So as you perform this procedure more and more, you're going to get used to how much of leeway you want to leave yourself. You remember when you're cutting, leave enough, because if your patient takes a breath in, you're going to lose a little bit of your wire, or a little bit of the wire. So you don't want to cut it too short. You can see here, I always tell everyone the tip is when you're cutting these wires, you want to get the sharp part of the scissor away from the bowed part, because it's just sharper where the blade is, and it'll decrease the amount of fraying, because if you fray the wire, it'll hurt more as it comes through the skin. Okay, so here's the wire. You can see that they've already pulled it under the skin. So now it's just the stitch that's holding it in place on the other side. You'll release the other one on the other side because we pulled both wires at once. There you go. So they've undone the loop on the other side as well. You'll tell the patient to take a deep breath in and then pull on the exhale. And then you'll look at your wire integrity. So, you can see a little bit of tissue on the one wire, but from this photo, they both look intact. You make sure to document that. So post-pasting wire removal, you want your patient to be on bed rest for at least an hour. They need to stay on the cardiac monitors for at least 4 hours. And you want to assess for signs of cardiac tamponade or arrhythmia. So when we document our procedure, we want to say if we gave any pre-medication, how it went, the integrity of the wires, like I said. We also, when we had paper charts, we would always print off our ECG. What am I thinking? An ECG strip before and after, just to document that there weren't any changes. Okay, so after we remove our pacing wires, we can remove our chest tubes. In terms of timing, we don't wait too long after we take out the pacing wires until we take out our chest tubes. You kind of give it a few minutes, and if tamponade is going to happen, it usually does happen pretty soon. So it's at Sick Kids, we kind of take out like I said, we take out our wires and we take out our chest tubes pretty soon afterwards, like within the same 5 minutes, I would say. So you need a medical order. Right now, we're going with, for the majority of patients, less than 4 mils per kilo per chest tube in the last 24 hours, we are doing a chest tube quality improvement project where we've kind of done it for almost 2 years now. And so we might look at changing the policy to increase our volume threshold. But for now, our policy says less than 4 mils per kilo. So that's what I'll teach today. Um, so like I said, you just removed your pacing wires to make sure to look out for any increased chest tube drainage. If you do see an increase in drainage, then just pause, let the team know, and we'll reassess. You want to have adequate pain management. So for our kids, we give a good dose of morphine, and more often now for kids over 2 years, we've been giving oral Ativan on the ward. If they're in the ICU, they're getting a little bit more than that. I think some fentanyl and ketamine at times. And then for our kids who are technically over 6 months, but I would say we do it more in kids over a year when they're a little bit more of aware what's going on. We can ask our mobile sedation team, which is a team of anesthesia assists, to come up to the ward and give IV sedatives. Most of the time, in terms of pain, older kids will tell us that the chest tube removal itself, again, feels like burning, but the pain is pretty quick. It's just the pull of the tube, and once it's out, they feel much better. So for us, we're starting to realize it's more of an anxiety piece of having lots of people come in the room, not really knowing what to expect. And that's why it's really important to advocate for some anti-anxiety meds as well as the pain meds. And you can tell patients this too when you're prepping them, about the burning sensation, about how the pain really does go away quite quickly. Most of the times it's the anticipation of the procedure that causes kids to be worried. And when they're younger and can't verbalize that, that's what causes them to kick and cry. They just don't like that we're there. Before you take out your chest tubes, you want to do your chest assessment. So note their baseline work of breathing and lung sounds. Okay, so when don't we remove chest tubes? So if your patient still has an intracardiac line, so like an RA line, then we'd keep our chest tubes in until those are removed. If we see a big pleural effusion on X-ray or a pneumothorax, then of course that's a discussion about what that patient needs. Is that chest tube working? But essentially, we would pause and regroup as a team if we saw those findings on chest X-ray. Of course, we wouldn't remove a chest tube if you tell us that they're having a respiratory change prior to the procedure. We would again reassess the patient and see if we should go ahead or not. This is also a little bit dated about the increase in drainage. It would really be more of a discussion looking at the drainage. Is it because they just got up for the first time or moved for the first time? We might still go ahead with chest tube removal, but it does warrant a discussion with the team. If there's evidence of an air leak, again, we need to reassess of why there's an air leak. We need to do some imaging to see if we have a pneumothorax. We should always have an in-house and this should say cardiac surgeon, in case we need to reinsert the chest tube. Okay, here's an X-ray example of the chest tube. So all our chest tubes do have X-ray coating on them so that we can see them. So those are the white stripes you see. And again, you can see this kid, he still has their CVL and still has, they'll always have their wires. You can still see they have their pacing wires in, both the atrial and ventricular wire. And I don't see a fusion or a pneumo on this X-ray. So this kitty, if the drainage was low, those chest tubes could come out. Okay, what you'll need. So you'll need everything you need for your pacing wire removal. Like I said, we usually do both in one go. So your gown, your gloves, your mask, your goggles. You need to be trained in chest tube removal. You need to be trained with pacing wire removal as well. And you'll often need a couple more hands. You definitely need one more hand to hold the site as you pull and before you tie off the sutures. But sometimes, like I alluded to with older kids or just more active kids, for their safety, you just need someone to help hold their limbs from kicking. So those are that's the equipment all listed out. I think, like I said, Carrie's going to have a example session, so you'll see all this stuff. So you need a little bit different from the wire removal. You'll need Kelly clamps, betadine, swabs, scissors again, the suture removal again, Vaseline, bandage. The patient needs to be on the SAT monitor, and you'll need your stethoscope for your assessment. Okay, so here are our chest tubes. So you can see this patient has 3. You can see there's a few sutures or strings on here. So the black string, the surgeons put 2 types of sutures in for us. Your purse string, so that's the suture that creates that circle. I don't know if you can tell on the photo. And then the second is our retention suture, and that's what's holding the chest tube to the skin. So you want to cut the retention suture so that the chest tube is no longer attached to the skin, and you want to keep your purse strings intact so that you can actually tie, so that we can help close that exit site. So you can see here, the nurses are cleaning around the site with betadine. So you want to clamp off, make sure your bulbs are not on suction before you're cutting. So you can see here that, I'll go back, the purse string was pretty long. You kind of unwrap it. So you can see how it's wrapped on that center one, and then you'll unwrap it, and you'll cut the knot. You'll see a knot when you unwrap, there'll be a knot. You cut it so that you can tie. This will make more sense when you see Carrie do it. Okay, so they've clamped off. They've already cut the knot off of their purse strings. It's all ready to go. They'll prepare their gauze likely with Vaseline on the side, but you'll have your own systematic way of doing it once you start doing it more. Okay, so you can see here that they're cutting the retention suture. A lot of people tell you to look for the church steeple or the triangle. Again, when you start doing it in real life, you'll see better. Here's a drawing of it. So you can see the one that creates a circle is our purse string, and then the one that connects to the skin is your retention suture. So you can see those 2 bold dots, those will tie together, those strings, okay? Here's another nice photo of it. So we're cutting the red, that's the one that's attaching the chest tube to the patient, and then the blue is what we're gonna tie with. Okay, so we're all ready. The chest tubes have been released. Sometimes you kind of just turn the chest tube a little to make sure you got the right one, or that, there wasn't a mistake made in the OR with new residents, fellows. And then hello? Hopefully that's all okay. There's just a cold. Okay, so you can see that the chest tubes are, the retention sutures have been cut. The chest tube should be free to come out. One person is gonna pull the tube and then tie the purse strings to close the exit site. And you can see there's the second pair of hands who will be holding the exit sites to prevent air from coming in as the other person is pulling and then eventually tying. So if you're the person who's holding the exit site, you're gonna hold that until the occlusive dressing is on, okay? So I always remind people to just, not rush. As long as somebody's holding that site down, you are preventing air from getting in. Just take your time, do it right. People always often ask me if you should do a double pull or a single pull. It really depends on your comfort, and it depends on how far away the chest tubes are from each other. So while you're starting out, just do one at a time. There's nothing wrong with that. Okay, so you can see one of the chest tubes came out, and Sometimes you do see kind of that fluid coming out, so you can just dry that with gauze. So they're about to tie, so we do 3 knots. And like I said, the second person is holding this whole time. I think this photo is just showing them doing the second tube. They're holding. You can see a lot of, sometimes clots come out like that. Just clean it up with gauze before you put the occlusive dressing on. So see this person's still holding. You can see all the chest tube sites are tied now, which is great, and they're all cleaned up. So the other person's just getting the Vaseline dressing. So it's an elastoplast with a little bit of Vaseline on it to occlude the exit sites. Okay, and then they'll be done. So after you're finished and the occlusive dressing's on, the person who's holding can take their hands off, and the primary nurse will assess the worker breathing, listen to the lung sounds again, monitor for pneumothorax, and for pleural effusion. Though pleural effusion is a little bit slower to accumulate, we want to document our procedure, and we want to give the patient and family some education, which would be that we could take the occlusive dressing off in 48 hours to monitor for signs of increased work of breathing. We want to look for signs of increased oxygen needs, respiratory distress. If the patient has a pneumothorax, that's something that you'll see pretty soon after the chest tube pull. And it's not that common. Okay, troubleshooting. So if you are meeting resistance with either chest tube or pacing wires, we always just say give it your best tug that you're comfortable with. And then if it's not coming out, then just pause. And, if you've already kind of released the retention suture and you just keep, whoever's holding, just keep holding the exit site down and page the surgeon, and they'll come and they'll likely give it just a stronger yank. And I would say most of the time it comes out. Every now and then, or I think maybe once in the past few years, we've had to keep one wire in, and we just document that, but that's not the majority of cases, so I wouldn't worry about it or just call the surgeon. Omentum versus fibrin clots. Sometimes omentum, which kind of covers your GI organs, like it's just this, like helps make it smooth. This doesn't happen as often. If you think it's omentum, just pause again, call the surgeon. Usually it's clot, and you can tell the difference between the two, because one is very dark and looks like, I don't know if you've ever seen liver, and the other one's, the omentum is more smooth, and you can kind of tell that it's not just one piece, it's like a piece of a larger whole, and so you'll just pause. And then of course bleeding. All these troubleshooting, you'll eventually have to call the surgeon, and they'll help us troubleshoot. Okay, and that is the end of my part.
Thank you, Vivian. Thank you for that. You did all the hard part, all the theory. Thank you very much. Before we move on to the demonstration, does anyone have any questions for Vivian? Okay, it doesn't seem like we have any questions. Are you still there, Vivian?
Yeah.
Okay, well, thanks very much, Vivian. And we're going to proceed now with the demonstration. Just to make it better visibility for you, I recorded it ahead of time so that we could have nice close-up viewing for you. So first, I'm going to show the procedure for pacing wire removal, and then we will go through chest tube removal. So let me just make sure, sometimes, let me just share this again. We have to make sure I share my computer sound. There we go. Okay. Can everyone see? I have the video pulled up now. Is that what's visible to you? Are you still there, Vivian? Can you tell me if you can see it?
Yeah, I can see it.
Okay, wonderful. Okay,
Yes, thank
so thank you. I'm going to start playing it. Please
I see
unmute
it.
your mic if you can't hear it. Everyone should be able to hear it now. So we'll get started.
Prepare your equipment such as 2% chlorhexidine, 70% alcohol swab sticks, a suture removal kit, and band-aids. Don your PPE such as gowns, gloves, masks, and eye protection. To prevent infection, cleanse the skin and exposed wire surface with chlorhexidine 2% and alcohol 70%. Allow to fully dry. If the patient is sensitive to chlorhexidine, you can clean with betadine. Apply gentle traction to the knotted area of the wire to confirm which end connects to the pacemaker. Cut the atrial wire close to the skin at the side that would attach to the pacemaker, and then pull the wire through. Then do the same for the ventricular wires. With gloved hands, pull both wires simultaneously using gentle traction and continuous motion in the direction of the patient's feet until release from the epicardium is felt and the wire is completely removed from the patient's skin. We pull the wires at the same time to minimize discomfort for the patient. If strong resistance is felt, stop the procedure and notify the physician. Gentle traction and continuous pulling motion reduces the risk of bleeding and cardiac tamponade. Inspect the wire ends after removal to ensure that they have been removed intact and that fragmentation has not occurred. Notify the physician if fragmentation is suspected, as this can later lead to infection. If bleeding occurs at the insertion site, apply direct pressure with sterile gauze until bleeding resolves. Notify the physician in cases of severe or prolonged bleeding. Dress the exit sites with small sterile bandages for 24 hours. To minimize the risk of bleeding, instruct the patient to lay down and rest for a minimum of 1 hour. Crying babies can of course be picked up and held to help comfort them. To detect early signs of tamponade, such as tachycardia, place the patient on continuous electronic ECG monitoring for a minimum of 4 hours post-procedure. Document the procedure, and then clinically assess the patient for signs and symptoms of complications for a minimum of 4 hours.
So that was pacing wire removal. Does anyone have any questions about or comments about the pacing wire removal? Okay, so in that case, we'll proceed to review the demonstration of chest tube removal.
You can see here we've prepared our equipment. We have a bandage that has a thin layer of petroleum jelly on it to create an occlusive dressing. We also have betadine, we have a sterile suture removal kit, and we have a clean pair of scissors not shown here. Don your PPE and remove the chest tube from suction to decrease the potential for trapping tissue in the tube. Clean the skin around the chest drain with betadine and allow to dry until a matte appearance. This usually takes about 1 minute. Remove the steri strip and then unwind the purse string suture. We are using forceps here to point out the differences between the sutures. Here is the retention suture. This is the suture that keeps the drain in place. This suture here is the purse suture. You can see that as I pull on it, it's connected to the purse strings that I'm going to tie after we remove the drain. So this here is the retention suture. That's the one we want to cut. I'm now going to prepare the purse string sutures by cutting them with the clean scissors so that I can tie the first half knot. I am now going to cut the retention suture. To confirm that the retention suture has been released, just rotate the tube a little bit to ensure that it has been cut properly. I am now going to put some tension on the knot before we pull out the drain. To prevent air from entering the patient, have your second nurse place a couple of gloved fingers firmly above the drain insertion site and maintain pressure until the drain is fully removed, the suture is tied, and the occlusive dressing is in place. If appropriate, ask the patient to perform the Valsalva maneuver during pulling the drain. When you pull it, you want to pull in a rapid, continuous, firm, and smooth tug. If the child's crying, perform the removal during crying rather than inspiration. After removal, you might notice there's a bit of bleeding or the skin is wet. Just blot it dry with a sterile gauze before applying your occlusive dressing to make sure that it sticks. Assess your patient's respiratory and cardiac status and observe for signs and symptoms of pneumothorax, such as respiratory distress, decreased air entry, and the sound of sucking air. Prepare your equipment, such as 2% chlorhexidine, 70% alcohol swab sticks, a suture removal kit, and Band-Aids. Don your PPE, such as gowns, gloves, masks, and eye protection. To prevent infection, cleanse the skin and exposed wire surface with chlorhexidine 2% and alcohol 70%. Allow to fully dry. If the patient's sensitive to chlorhexidine, you can clean with betadine. Apply gentle traction to the knotted area of the wire to confirm which end connects to the pacemaker. Cut the atrial wire close to the skin at the side that would attach to the pacemaker and then pull the wire through. Then do the same for the ventricular wires.
Sorry, everyone. I got distracted there and I realized we're showing the pacing wires again. So I'll actually finish showing that. Sorry about that. And we are going to, after that, we're going to have a very short break and resume at 1:15. So in about 10 minutes. So I'll just finish playing this since it already started.
With gloved hands, pull both wires simultaneously using gentle traction and continuous motion in the direction of the patient's feet until release from the epicardium is felt and the wire is completely removed from the patient's skin. We pull the wires at the same time to minimize discomfort for the patient. If strong resistance is felt, stop the procedure and notify the physician. Gentle traction and continuous pulling motion reduces the risk of bleeding and cardiac tamponade. Inspect the wire ends after removal to ensure that they have been removed intact and that fragmentation has not occurred. Notify the physician if fragmentation is suspected, as this can later lead to infection. If bleeding occurs at the insertion site, apply direct pressure with sterile gauze until bleeding resolves. Notify the physician in cases of severe or prolonged bleeding. Dress the exit sites with small sterile bandages for 24 hours. To minimize the risk of bleeding, instruct the patient to lay down and rest for a minimum of 1 hour. Crying babies can of course be picked up and held to help comfort them. To detect early signs of tamponade, such as tachycardia, place the patient on continuous electronic ECG monitoring for a minimum of 4 hours post-procedure. Document the procedure, and then clinically assess the patient for signs and symptoms of complications for a minimum of 4 hours.
Okay, thank you, everyone. I hope that provided, or we hope that that provided a nice up-close and visualization of both procedures. We were so close, in fact, you could see every little piece of lint on our mannequins. So in the future, I think for next year, we will try and get some footage on an actual patient. But thank you for watching. And if you have any questions, please feel to unmute your mic and go ahead.
Mine's more of a comment. Just at CHEO, the nurses don't remove the pacer wires or the chest tubes. It's the surgeon that does it.
Yeah. We, before we established our nurse pacing wire and chest tube removal program, it was certainly our surgeons that did that. And then we developed our program. We have a pretty rigorous program where the nurses they attend the oral session that you attended. They have some hands-on practice, and then in lab setting, and then they have to have 5 sign-offs by one of our much more seasoned core team members. They get 5 sign-offs at a minimum for both procedures, chest tube and pacing wire, and then submit that. And that's really to ensure for our quality assurance. But not all centers have the same program. But hopefully you could see some similarities here in terms of the procedure and some of the safety precautions for preparation during and post. Thanks for the comment.
I think part of it at GEO is we don't do as many cases as well. So it'd be impossible, I think, at your site for the surgeon to remove them all. Am I right? Or
yeah, so one was we did find that sometimes the surgeons weren't, as you know, they are not always readily available. And so, we had some situations, and we've had our program for I would say probably at least 20 years now. We were finding that, some patients would have delayed chest tube or wire removal because of the surgeon not being available. In some circumstances, maybe waiting all weekend, for example. The other thing is the timing for analgesia and sedation. If it's the primary nurse or another nurse that's removing it, we seem to have a little bit more control in orchestrating the plan of care, like timing analgesia, sedation, even working around simple things like the patient and family schedule, like nap time and things like that. So we definitely see some benefits around that. So that's our kind of background.
And I guess one last comment is our surgeon wraps the wires around a clamp and then yanks them.
Oh, okay. So to provide the a bit of extra tension.
I guess so. Yeah.
Yeah.
And I have seen when the CV fellows pulled them out and torn them having a big bleed afterwards with the chest tubes.
Mm-hmm.
So I noticed that you said don't wait that long in between, but when the pacer wires are pulled out, there was a hemorrhage, so that was picked up in the chest tube.
Yeah, so that's an excellent point you raised, and that ideally we remove our pacing wires first and then our chest tubes. The idea there is if they were to do exactly what you said, have a tamponade or an exsanguination, that if the tube was in that general vicinity, that we would pick that up. And it's pretty scary when it does happen. It's not very often, but it certainly can. It certainly can happen. Tamponade can happen after pacing wire removal.
Yeah, and that patient obviously had to go back to the OR.
Yeah, it's pretty concerning when that happens, isn't it?
Yes, thanks for listening to all my comments.
No, it's great to share experiences because these things, while they're rare, they do happen. Okay, well, if there isn't any other comments, again, thanks for your attention. And Cecilia will be on in a few minutes, probably about 5 or 6 minutes, and we'll resume then. Thanks very much.